Hello, my name is Dr. Jamie Van Gumpel. I'm a professor in neurosurgery at the Mayo Clinic in Rochester, and I'm presenting single photon emission computed tomography and epilepsy surgery evaluation um, in association with my colleagues, Dr. Benjamin Brinkman and Dr. Gregory Casino in neurology at the Mayo Clinic. Focal epilepsy, the most common of seizure disorders, may be amenable to surgery if the seizure onset zone can be identified and its ablation is expected to result in low morbidity. Localization, therefore, is key to surgical remediable epilepsy syndromes. In lesional cases in which the MRI demonstrates a lesion, no further workup is commonly needed unless there is question as to what the associated seizure onset zone is, or alternatively, if there is discordance with the data and the seizure semiology. However, in non-lesional cases, alternative techniques such as single photon emission, computed tomography, also known as SPECT, can be very helpful in identifying potential seizure onset areas. SPECT is used in lesional epilepsy patients in whom the semiology appears focal as a way of localizing a potential target for implantation of intracranial electrodes, or alternatively, for providing alternative hypothesis for the epilepsy onset zone. No epilepsy center would resect a SPECT focus simply based on the presence and correlation with semiology, but rather epilepsy centers use it as an implantation target or hypothesis generator for intracranial electrodes to prove seizure onset before resecting. So how does SPECT work? It's an imaging technique that assesses cerebral blood flow by deposition of a metabolized radiopharmaceutical in the brain. Technetium 99M-ethyl cystinate diethylester, ECD, are also known as Neurolite, or hexamethyl propylene amine oxime, HMPAO, or Serotek, are the two most commonly used agents, and they are distributed to brain tissue in proportion to cerebral perfusion. It is deposited and remains stable in the area in which it is metabolized for up to 4 hours after injection. So how does SPECT work? Well, this deposition is used to indicate an area that are either hyperperfused during a seizure, this is called ictal SPECT, or hypoperfused after or between seizures. So interictal SPECTs can demonstrate seizure focuses commonly to be hypometabolic, and these can be utilized. In this figure below, we see what a typical SPECT exam looks pre-injection, or in panel A. This would be an interictal SPECT exam. In B, after a seizure onset has occurred, an injection shows hypermetabolic area or deposition in the left temporal lobe. And when we subtract B from C, this shows a high area of increased metabolism in the left temporal lobe. And this allows us to correlate our seizure onset site with this. Ictal SPECT, again, the two tracers at which we mentioned above are used. There's no difference known in these imaging outcomes, sensitivity or specificity between these tracers. They all have high first-pass brain extraction with nearly complete deposition in target tissues within 30 to 60 seconds of IV injection. And again, of course, assuming that the epilepsy onset zone is a runaway electrical activity, there's a presumption that this will increase the amount of metabolism that's metabolated and they have it deposed in the area of epilepsy. So this is the example workflow in a clinical patient. They're undergoing video EEG, and the patient has a seizure. Alerts unit staff, the staff after experiencing the first signs of the aura, and most commonly accompanies a typical seizure. 15 seconds into that seizure, a technician is able to inject the tracer agent. While the seizure continues for an additional 40 seconds, a seizure lasting 55 seconds in total. Of course, the technician must be at bedside, must be always ready with this agent and ready to inject. The patient is then taken to nuclear medicine department, typically within 4 hours of the injection, and they're scanned using a tomographic gamma camera capable of detecting the gamma ray emissions of the deposited radiopharmaceutical. Very commonly, an exam is done prior to the injection when the patient is not having seizures. There can be false negatives when patients have frequent seizures in this particular circumstance. The injection timing is critical, so less than 45 seconds from ictal onset is very critical to having a good overall outcome. Longer seizures do not allow for a later injection. This is because the tissue becomes metabolically deactivated as the seizure goes on. In cases in which the tracer has been injected too late, the imaging may be falsely localizing, or the seizure focus may actually be hypoperfusion rather than expected hyperperfusion due to the seizure onset metabolic burnout. Ictal SPECT has been shown to be most valuable in lobar localization and hemispheric lateralization as to which side the activity is on. Ictal SPECT, of course, I've said this several times now, and what this simply means is that this is performed during the seizure. The seizure onset zone can be expected to be identified by hyperperfusion or increased signal. Interictal SPECT is typically performed to provide a baseline context for the ictal hyperperfusion. The seizure onset zone may exhibit decreased perfusion interictally, although this is not as reliable as the hyperperfusion on the ictal scan, obviously. Interictal SPECT is proved to have a low sensitivity and high false positive rates in patients with temporal and extratemporal seizures. Therefore, if you are to get one, only the ictal SPECT is the most important. SysCom is a separate technique in which there is a subtraction of the patient's interictal SPECT from their ictal SPECT imaging, and there's a subsequent fusion of this imaging and overlay onto an MRI. This has been termed SysCom, and this allows some anatomical overlap. This methodology is thought to enhance the anatomical accuracy of the SPECT images as well as demonstrate more accurately the focus of hyperperfusion associated with the seizure. Further, it enhances surgical planning because the computer-generated estimation of the SPECT abnormality projected over the high-resolution anatomy of the MRI is useful for stereotactic planning. And here's an example of a patient with a SysCom exam in which B represents a interictal SPECT exam, A demonstrates an ictal SPECT exam in an area of a patient that had seizures adjacent to motor cortex and had leg-related reflex epilepsy. And this little hyperdense area here overlaid on the MRI correlates with the motor cortex area involved. And you can see there's always other areas involved as well that may be involved in motor pathways, such as a cerebellum. Of course, the imaging has to correlate with the patient's semiology. An additional testing is statistical parameter mapping and status count. These techniques seek to determine any significant perfusion differences between a patient scan and normal variations seen within a neurologically normal population. What this means is we commonly take a subset of patients, typically with SPM mapping 20 patients, and compare this to the abnormal patient. StatusCom comparisons between the patient's SPECT exam and a set of paired SPECT scans from normal subjects, typically 20 or more. That's called statistical parametric mapping, or SPM. There's a recently developed technique to perform the statistical testing with ictal and interictal images and include ictal SPECT analysis by SPM and statistical ictal SPECT co-registration to MRI, which is known as StatusCom. And this is a typical SPM outlay in which there is an area of hyperperfusion in the medial temporal lobe and an area of hypoperfusion relative to normals in the cingulate on the ipsilateral side. So what are the limitations of SPECT? Well, SPECT is a very time and resource intensive study. Getting the radioisotopes in quickly is difficult and requires well-trained technicians and time and good alert systems. Obviously, this imaging method is best suited for patients with long auras or seizure prodromes. And if there's a long delay on the injection of the tracer agent, there's concern that the perfusion changes may represent propagated activity and seizure spread rather than a defined seizure onset, which can lead to misinterpretation of the data. And outcomes associated with SPECT. SPECT localization as part of the surgical assessment process has been reported to be an independent predictor of post-resective angle class 1 outcomes of both temporal and extratemporal cases. Notably for this data is within the chapter, and you can seek the citations there. Therefore, they're not placed on these slides. The temporal lobe seizures, a sensitivity of SPECT relative to diagnostic evaluation was 0.97 for ictal SPECT, in which the injection was less than 45 seconds from the seizure onset, therefore very highly correlated. In a large series of 155 patients from our institution, where 68% were extratemporal and 50% were non-lesional, SysCom was concordant with the ultimate resected surgery site in 70% of these patients, and indeterminate or discordant in all others. Desi and colleagues were compared concordant preoperative hypometabolic areas of PET imaging and ictal SPECT imaging with a confirmed intracranial EEG focus and found PET to be 56% sensitive and SPECT to be 87% sensitive. In a series of patients, 51 evaluated by both ictal SPECT and SysCom, there was a higher rate of localization of seizure focus with SysCom, 39 versus 88%. With SysCom, there was less inter-observer variability as well as improved seizure outcomes compared with SPECT interpretation in the same individual. Therefore, in conclusion, SPECT is a reliable and important imaging technique facilitating hemispheric lateralization and lobar or sublobar localization in many non-lesional epilepsy cases. Ictal SPECT, unlike other functional imaging modalities of epilepsy evaluation such as PET and MEG, is an attempt to image the seizure itself rather than the epileptic brain between seizures. SPECT alone is not a sufficient imaging modality, but when there is concordance with semiology, it provides adjunctive data to guide intracranial electrode implantation. It is critical that the surgeon have a firm understanding of the factors that would make a SPECT or SysCom study unreliable or misleading, such as a later potentially post-ictal injection. SPECT imaging remains an important tool in developing an implantation hypothesis, and if used correctly, can improve your surgical success.